Cancer is a word that none of us would ever like to hear in our life. It's something that we all wish we could live in blissful ignorance of, knowing it exists yet never coming into contact with it. Yet, in reality, we know we can't ignore it. Each one of us have most likely been personally affected by cancer, whether it be a loved one, a friend, or ourselves. According to the National Cancer Institute, about 2 out of every 5 individuals will develop cancer in their lifetime. Of these 1,685,210 people, 595,690 people will lose their battle with the disease. Cancer is the emperor of all maladies, the king of illnesses, and it's something that we can no longer avoid. It's been around since ancient Egyptian times, and yet we are just now beginning to grasp the molecular makeup of the disease. It is new, it is unprecedented, it is exciting. It is like nothing the medical field has ever seen before, and it is something that I want to be a part of. I want to help those who are afflicted with it, I want to research and study it, and I want to be a part of the revolution of cancer treatment. The famous theoretical physicist Albert Einstein once said, "The significant problems we have cannot be solved with the same level of thinking with which we created them." This quote applies not only to my ISM journey, but to my topic of study. If we ever want to cure cancer, we have to expand our knowledge beyond what we thought was possible. We cannot think at the same level we have been thinking and expect to find the answer. We must push the boundaries and challenge our knowledge of both medicine and cancer itself. This mirrors what I want to do this year in ISM. I want to push myself beyond the boundaries of comfort. I want to challenge myself to grow as a person and to think at an entirely new level and to continue to expand my knowledge of cancer. Throughout the year in ISM, we conduct extensive research on our topic of study. This research includes articles and online research, but it also includes face-to-face interviews with professionals currently working in our field of choice. The first interview I conducted was with Dr. John Mansour, a surgical oncologist at UT Southwestern Medical Center. My interview with Dr. Mansour enlightened me to the fact that I was personally better suited for surgical oncology than medical oncology, which I went into the year thinking was what I wanted to do. I was fascinated as he discussed the various operations he performs and how close the relationship between the surgeon and the patient is. That was something that I thought could only be found in medical doctors, this tight-knit bond between doctor and patient. But Dr. Mansour enlightened me to the fact that surgeons have this relationship as well. We also discussed the ethical and moral dilemmas that come with the advancement of medicine. As we discover more protein sequences and what they mean for each tumor, we are also given a heavy burden of responsibility. With the ability to determine how a tumor is going to act, whether it will grow quickly or slowly, whether it will metastasize or not, we can individualize treatment to each patient, but we can also determine whether or not treatment will be effective. This presents an ethical dilemma for doctors as they move forward with treatment and the revolution of cancer. Dr. Mansour and I also discussed the unusual clarity that cancer patients have and how that helps many cancer doctors to stay grounded throughout difficult times or loss of patients. Ethics and morals don't only affect cancer cases, as I discovered in my interview with Dr. Victor Aquino, a pediatric oncologist and hematologist at Children's Medical Center. Dr. Aquino focuses mainly on pediatric blood disorders such as leukemia and anemias, but he also focuses on bone marrow transplants, or BMTs. These transplants can greatly affect the immune system of children and greatly compromise their ability to fight diseases, and therefore Dr. Aquino has helped to develop a special ward for just these BMT patients to keep them separate from diseases such as the cold or the flu that could potentially threaten their well-being. Dr. Aquino and I also discussed clinical trials. Pediatrics has a much more cure cancer mindset than adult cancer patients do, which I found to be very interesting. Approximately 95% of the oncologists and hematologists at Children's Medical Center will participate in a clinical trial, which just goes back to that cure cancer mindset that most pediatric doctors have. So I decided that I wanted to explore every area of oncology, which is an incredibly broad field. So my next interview was with Dr. Edward Pan, a neuro-oncologist at UT Southwestern. Dr. Pan treats mainly gliomas and glioblastomas, and a glioblastoma is an incredibly aggressive form of cancer that unfortunately results in a very low survival rate. Dr. Pan said that when treating patients with cancer, you can't expect miracles and crazy life-saving treatments, but you have to celebrate the little successes. In a field where you lose so many of your patients, you have to learn to find success in everyday things. Whether it be telling a patient that your tumor's gone down, it hasn't been completely resected, but it's on its way. Or whether it be telling a patient that due to treatment, we're thinking that you may live a month longer than you were supposed to. You have to find successes in the everyday. This helped me to prepare for the inevitable and difficult conversations that I will most likely sit in throughout the year and will eventually have to have on my own. My next interview was with Dr. Patrick Levy, a pediatric here we go. We also discussed MRIs and how they've changed and how they need to change. So if you look at this MRI on the left, you can see a large white patch on the brain. Now, for a doctor, this can be interpreted in many different ways. It can be interpreted as a tumor, it can be interpreted as scar tissue, or it can be interpreted as what it actually is, which is swelling. If you look on the right, that small black area that is defined, that is the actual tumor. So you can see how the MRIs, how the tumor actually varies, and how the read off an MRI can vary, depending on swelling or scar tissue. This is something that Dr. Pan actually is working on fixing and is wanting to see change in the next 10 or so years. The development of better technology for MRIs, so that way they can better determine what's a tumor and what's not in the brain. My next interview was with Dr. Patrick Levy, a pediatric oncologist and hematologist at Children's Medical Center. I really enjoyed talking to Dr. Levy because we discussed a lot of how he deals with the loss of his patients. I found him to be an incredibly compassionate doctor, and he actually showed me his photo album of all the patients he had ever treated and those he had lost, those he had saved as well, and I found that to be incredibly gripping and compelling. We also discussed a lot of the research that he does. Dr. Levy treats mainly sarcomas, which are solid mass tumors, and he participates in a lot of research regarding these tumors. One of the main forms of research that don't necessarily deal with sarcomas but do deal with pediatric cancer that he has been involved with are CAR T cells in leukemia patients. CAR T stands for chimeric antigen receptor T cells, which are a fusion of B and T lymphocytes. And these cells, when infused back into the patient, can actually cure children of their leukemia, which is a major breakthrough in the personalization and overall treatment of cancer. My next interview was with Dr. Christopher Madden, a neurosurgeon at UT Southwestern Medical Center. This interview was very difficult for me just because of the conversation that was conducted between myself and the professional. I didn't gain a lot of medical knowledge from this interview, but I did gain valuable insight into the medical field. This field, especially surgery, is not for the faint of heart. It's not for those who aren't passionate about what they do. It's not for those who are just simply looking for a job that pays well. This field is for people who are dedicated to making a tangible difference in the lives of people across the country. It's for people who are willing to accept delayed gratification, for people who are wanting to make connections with others, and for people who are willing to do whatever it takes to save a life. This interview opened my eyes to what kind of doctor I want to become, one that is incredibly knowledgeable and precise, yet ultimately is able to connect with the patients on a deeper level and conduct those difficult conversations that are inevitable. I want to be the kind of doctor to give good news, but the kind of doctor that is also willing to sit with you and suffer through the bad news. My final interview was with Dr. Joseph Murphy, a pediatric surgeon at Children's Medical Center. Although pediatric surgery isn't specific to tumors, I decided that I wanted to explore as many options as I could and learn from as many perspectives as possible throughout this process. Dr. Murphy and I discussed some of the various surgeries he performed, including those to correct congenital anomalies. One of the more interesting ones we discussed was gastroschisis, a congenital anomaly in which the child is born with their intestinal organs outside of their body. And he sees a surprising amount of these cases. I didn't even know that that was a thing, but I was particularly enlightened to learn about that malady. We also discussed how important it is to be able to accept delayed gratification. This is not a profession in which you begin working immediately after college, but rather have to endure 12 to 14 more years of grueling hours in education. So you have to be willing to wade through that and work as hard as you can to be able to accept that gratification from patients and their families. While we conduct informational interviews, we also conduct research on various articles. The majority of my research has been focused on two things, one of which being metastases and how they affect treatment. So metastasis is the spread from a primary tumor to a secondary location. They travel primarily through the bloodstream or through the lymphatic system. Once a tumor metastasizes, it becomes much more difficult to treat because the tumor nodes are spread all over the body. For example, in the treatment of pancreatic cancer, metastases affect the surgical process to remove the primary tumor. This process, called a Whipple, is unable to be completed after the tumor has metastasized. If the tumor has spread, the removal of the primary tumor would be futile, and therefore the operation is unable to go through. The other area that my research has been focused on is nanotechnology, focusing mainly on quantum dots and colloidal gold particles. So if you look up here, you can see the areas where the nanotechnology has actually illuminated tumors. So those are tumors in a rat, and they've inserted quantum dots into the rat, and they'll actually, the quantum dots will congregate in the tumors because of the wide vasculature that they have, and therefore they're able to actually illuminate the tumors to the naked eye. This is particularly beneficial in the field of surgical oncology because you're able to discover and create a defined boundary for the tumor, meaning that you can ensure that you've resected all of it, and not only the primary tumor but also micrometastases, which are small nodules of the tumor that have split off. I've actually decided to do my original work focusing on nanotechnology because quantum dots, while they have incredible benefits such as being able to illuminate a tumor, they're also fairly toxic to humans. So through my original work this year, I am going to figure out how to fuse a quantum dot with a colloidal gold particle, which is significantly less toxic to humans, but still retain the illumination and the benefits of quantum dots.